So what Zero Suicide is really a collection of the best practices in the field um, for suicide prevention. And it has a number of core principles, which again, it's not new, but they're basically an accumulation of the research and the best practices, and it's a way basically to work collaboratively to do this better. Okay, so how do you do that? So, what does that mean? So number one, the first principle of it is screen widely and use a validated tool that has been shown by research to help identify people who are at risk. So one of the greatest risks and the reasons that people fall through the cracks is that nobody asked. Okay? So part of the zero suicide approach, and again, it's not exclusively the zero suicide approach, but what the research has very clearly shown that you have to ask often and with a validated tool. So, for example, for us at Newport Mental Health, we already used a validated tool. The most frequently used tool is the Columbia screening tool for suicidality, but we weren't actually asking often enough. So we would ask somebody when they came in, as a new admission, and then at certain set times during their treatment later on. The best practice, and again, this is what we learned, how do we improve, is to ask somebody at every visit. Okay? So we're transitioning to asking at every visit. And it's sort of those, I'll call them micro adjustments, some of them are bigger than others, that if you make all of them, you basically tighten the safety net so people do not fall through. Okay? So that's number one. So screen, often use a validated tool. Step two is be prepared to respond quickly, and again, using sort of the best practice methodologies for the people that do actually indicate to you through your screening process that they may feel suicidal. Okay, so what are some of those practices? So one is absolutely with a person who's both licensed and trained to conduct a full assessment on someone who's indicated on your screening that they're feeling suicidal. Okay, so most of us, and myself as a clinician through our training, have been trained at some point in our careers how to do a full sort of clinical assessment for somebody who's saying they're suicidal. I've been doing this for 40 years, and I learned through this process that I was not necessarily using the best practices for doing that. There are certain questions that you need to ask. There are certain areas you need to cover to really get a full formulation. And again, there are standardized tools that are sort of designed to help you through that process. Okay? So again, we're bringing those tools into our practice. The Columbia screening tool actually has a full, longer version that gets much more in-depth. So you ask, if somebody's saying they're having suicidal thoughts, you ask about how frequently, how intense, are there certain situations that they arrive in that, again, if you ask certain questions a certain way, you are more likely to learn what you need to know to help make the assessment. Okay? So step two is a rapid response, and again, we've used some of the grant to beef up some of our mobile crisis response to make sure we can respond rapidly and to be asking the right questions.